these on your gram stain would be gram-positive cocci. These would be gram-positive bacilli. And they look in weird, you think of a Oriental or Chinese letters, little V formations, or they'll have L formations. And you look at your gram stain, you think, oh my gosh, that looks like the dipteroid. Though, if you had to pick two common normal flora that you'd want to learn for sure before you go to clinical, it would be the staph epi and the dipteroid appearance. And remember, we're going to build to that. That's why these I'm not putting on our test one. This is two ahead of the game. But by test, the last test, you should be able to understand those are normal flora. 28, 29, two normal flora of the genital urinary tract. The dipteroids are one, but in a female, lactobacillus is another gram-positive bacilli. And it doesn't look like a dipteroid. It doesn't look V formations or L or Oriental letters. It looks sometimes positive linked. They'll do end-to-end bacilli. They do a thing called palisading. So you get your gram-positive bacilli and they kind of stack. Or you'll see them end-to-end. So they don't do V formations or L formations. They do palisading, stacking, or end-to-end. And you better know on a female genital culture, the normal flora is going to be lactobacillus. They would be pretty upset if you go there by the end of the class and you get a genital culture and they say, well, what normal flora would you expect? They're going to expect you to know lactobacillus. So we've got to build that by the 8th week, you guys can understand what normal flora you expect in different areas. I have a really good worksheet that I want you to put in your clinical folder. It does the clinical specimen type, and it'll have a column for normal flora and a column for pathogens. So if you can't, they ask you, okay, what normal flora, this is genital culture, what do you expect? And you say, can I at least look in my folder? I don't know off the top of my head. They'll at least appreciate that you took the effort to go look at your folder and look at that you have it with you. So, they're going to appreciate effort. They know micro is just about here. I mean, there's no way around it. So they're not going to expect you to be a whiz, but they're going to at least appreciate if you have an effort more than, I don't know, I'm not sure, At least, so I try to give you a lot of tools that should help you, okay? And 30, so you tell me, what do you have for 2 factors that influence an infection? What? Virulence factors? What? I don't know what you say. Environment. Like, give me an example. What do you mean by environment? So, well, sometimes if you have an infection with an anaerobe, what do you think one of the things they could do to stop that infection? Put you in a hyperbaric chamber or a wound vac or something that promotes oxygen so it can't grow. So that would be an example if it's in the environment it loves. For instance, Pseudomonas loves moist environments. So where do you think a common place in the hospital has to be checked because it uses moist environments and they could harbor a Pseudomonas when they're treating the patient? Can you think of anything in the hospital setting that uses moist environments commonly? I'm sorry, what? What?
Burn unit.
Burn unit? Okay, they would, but what would they be using to treat them that would be a moist environment that could get infected with pseudo? All your respiratory care, that's a very moist environment if they don't clean those areas. And when they debride a burn in what? A whirlpool, we would periodically, when I was training in micro, when I was doing my rotation, they would get swabs from the Whirlpool tubs and physical therapy to make sure they didn't have nothing growing, that their cleaning process was good. What do you think? Hot tubs are dangerous at people's homes. If they don't clean them well enough, you could be harboring Pseudomonas. You know, people were in there and they have any kind of open sores or open area. So the environment in that case can make them more pathogenic. Is it a true pathogen? For instance, a true pathogen means even if you're healthy, you can still get it. So Shigella is one of the GI pathogens that doesn't take much to, Shigella doesn't take much to infect you, even if you're healthy. You might be exposed to as little 50 organisms, which isn't much to be exposed to, and you could get it if you're healthy. Some people will say it's an opportunistic bacterial infection. That means people who are sick will get it more easily. But if I'm a healthy person, I don't have any condition, I don't take any steroid like prednisone for maybe a lupus condition or something, I'm not going to get that because it's opportunistic. It only gets the patients who are already having a problem. So a true pathogen means it'll infect you. If all of us are exposed to Staph aureus, there's a good chance we're going to get it, even if we're really healthy. Okay? So is it a true pathogen? And do you remember which organism I told you had a virulence factor that was on the PowerPoint slide yesterday as one of the virulence factors? We talked about pili and fimbriae, which help attach. There was one other thing we said a bacteria could have around it that makes it more virulent.
Capsules.
And guess which organism we're doing in class? Strep pneumoniae is a classic one to have a capsule. And sometimes look at your plates, especially, a lot of times it starts auto-lysing after 48 hours. That one can have like the little donut shape, that strep pneumo, when you look at your plates today. Hey, why don't we stop here a minute and take a break? You're all looking like, okay? So if someone has to go to the bathroom or get a drink or, I'm gonna pull up the PowerPoint a minute and just see, yeah, just take a minute, because I feel like, okay, let me go. I don't think anybody's here. Hey, and Leah, did you not go to 2410 yesterday?
I did. There was a man in there.
No, because I asked Howard. He's the only man, and he was in the big office.
Where Barb was?
Barb in that little office there?
Yes. There was when I had to wait on him like to leave. He said he was just gonna be a minute.
What if he was one of our computer guys? Because I asked him to do Respondus for Diane to put a test on Blackboard, but
Yeah, I went to that room where you
Barb was.
Yeah.
2410. Okay. Your natural substances that are part of your innate immunity that help prevent infection. Your skin is your big one. That's why a burn victim is so susceptible. They lose their skin if it's a 3rd-degree burn. And that is a big one. What else? What do we have a lot of that we were just talking about? Normal flora. That GI tract normal flora. What happens to women commonly who get treated for a UTI? What happens? Commonly, what do they get after the UTI is cleared up? A yeast infection, because it disturbs the balance of normal flora, wipes out a lot of bacteria, and whatever yeast were present as normal flora can thrive and multiply. So your normal flora play a big role. Even your mucosal secretions. So your physical barriers play a big role. Your normal flora, all your secretions. Phagocytosis, you should remember in serology, phagocytosis is part of your natural immunity. When you have diapedesis, getting your white cells, your neutrophil, and then your monocyte becomes the macrophage, and gets out of your cell wall and is like a little Pac-Man going to the site to clear up infection. When it takes it in like a Pac-Man, that's phagocytosis. That is natural immunity. And if your white cells don't work properly, your monocytes don't become macrophages properly, your neutrophils don't work in phagocytosis properly, you're going to have more problems. And then you move to specific immunity, and what two cells were those from immunology? T cell, and you had the B cell and the T cell. And what two types of T cells did you have? You had CD4 helper T cells, and you had CD8 cytotoxic T cells. Those are, you know, the person who has HIV becomes full-blown AIDS because their CD4s bottom out. And what does CD4 do? CD4 not only helps your CD8s, it also helps B cells to proliferate and become plasma cells and produce antibodies. So all that immunity you learn impacts if a bacterial infection is going to take over, especially when you're talking about your bacterial infections. That B cell production is very critical. And you bottom out your CD4s, they're like the hallmark white cell. It helps everybody, okay? So those are resistance factors. How are common ways you get microorganisms on 32? Airborne. That's why we got to worry about aerosols. You would never spend anything in microbiology in a centrifuge uncapped. One thing I should have mentioned yesterday before we have lab, do you understand what sterile or aseptic technique is? What do you think you as a tech have to do to support good aseptic technique when you're looking at plates? Do you just open them up and leave them open to the air, just sitting there the whole time until everybody comes and looks? You don't want to keep plates open to the environment to have something come from the environment on it. So when you're doing anything, streaking, you don't want to set your loops out on the table and have 10 loops out sitting on your table and then use them for your plates. They should stay in the holder. Take it out as you use it, because how do you know what's on that table that you might introduce to the media? And we're just messing around for our practice, but if you're doing a real patient, don't you want to make sure that what grows is truly what's pathogenic from the specimen? So you as a tech always have to uphold aseptic technique. Don't open your plates. I got 10 blood plates I want to plate, so I'm just going to open all the lids to make it better for me. But then that whole time, by the time you got to plate 10, it's been open to the environment. And you can get bacteria that way too. So always be conscious of aseptic technique. You only want to grow what's infective in that patient's body fluid or in that throat or that urine. You don't want it impacted by your poor technique. Okay? Or reusing a loop on another culture by mistake because you didn't throw it away. So airborne is a big one we have to worry about. That's why we are limited to what we can do with fungus. We only have the hood in the back room, so I would never bring pathogens to work on in fungus. Because who has dimorphics as their thing to do on the study questions? There should be 2 of you that have the dimorphics like histoplasma. If you've looked at the list, there should be 2 of you that have histoplasma. Those are bad. The dimorphics are what you get from an aerosol inhaling. So we would never bring a dimorphic in to play around in lab. We don't have a great enough environment for everybody to work under the hood. So always be thinking aerosols is a brand new infectious process when we work with micro. Don't be flinging things around or your loops or anything. Anybody know how you get infected from your study questions in Mycobacterium with TB? Anybody know the name of what hangs suspended for hours within 3 feet of the patient coughing? It's called the droplet nuclei. You should know that for your registry. It is something, that's why they wear the mask within 3 feet of a patient. It can hang there if they're coughing profusely and they have TB. That's why they should be in isolation. So airborne is probably your #1 new problem with micro. What else? Think about your Enterobacteriaceae. If they have a lot of gastroenteritis, diarrhea as your sickness, what do you think would be the source? Ingested through food and water. So that is a big route of transmission. And then what do you think about your venereal diseases? Your STDs? Close contact. One of them could be with mononucleosis. They think of sharing saliva from a glass or whatever. Genital sexual contact with syphilis, with gonorrhea. So those are big routes of transmission. What are 2 key factors in collecting specimens properly? One, I think, would be kind of common sense, depending on where. Think of a blood culture. That's one of them. That's kind of common sense why you do sterile prep. So what do you think when you're collecting a blood culture would be key for it being accurate?
Procedure.
Contaminating it with what from the skin? Normal flora. So anytime you're going to make a collection that is close to normal flora, you've got to make sure you do a procedure or technique that avoids normal flora. So you're not working up a skin bacteria and you're wasting all that time and money for the patient, and it was all because the phlebotomist didn't do sterile prep. Or a stool. You know, there are going to be key features. Stool has a ton of normal flora. You as a tech got to know in that stool what is normal flora versus what could be the pathogens. So you're going to learn Salmonella and Shigella are non-lactose fermenters. So right off the bat, if you get a stool culture with a non-lactose fermenter, that is a big clue. Uh-oh, I might have that diarrhea caused because of Shigella Salmonella. E. coli is a LF. It's a lactose fermenter. So that already eliminates a lot of normal flora if you get a lactose fermenter growing heavily on the plate. So avoiding normal flora is a big deal with your collection. The other one, it makes sense if you can collect it in acute phase. For instance, strep throat. If you're sicker than a dog, have maybe the white pus puckus, maybe you have the fever, that's like your acute phase. Then you wait 2 weeks down the road and they're starting to feel better. It's going to be best if you can get the specimen collected in an acute phase when they're really sick. Did anybody write how you, on 34, what collection method should be used for a wound?
Needle aspiration.
And you want to know that for your registry. Do most sites collected by needle aspiration? I bet they use a swab still. But for the registry, you need to know needle aspiration. Why does it make sense if you go into a wound with a needle versus a bigger swab? What are you avoiding? Normal flora. Okay, if you have a wound and you don't want to get that skin flora, you're going to have better luck going with a fine point of a needle versus a swab, getting that collection. But I honestly don't think a lot of people use needle. Maybe on a body fluid that you're suspecting an infection, they'll needle aspirate it, but an actual wound. But that's what you should know for your registry is the needle aspiration. What should be, okay, and this we, as another common sense. What do you think you'll see if you don't get a good sputum collection? So this would be 35.
Saliva.
Tell me, what do you think you'll see on a gram stain if you've gotten saliva that might have contents from your mouth? Besides bacteria. Think of a cell you might see if it's truly from your mouth area, saliva. and it's something you're gonna have to do on every sputum to see if it's acceptable. You look for squamous epithelial cells. So you know how in urine we had the big fried egg appearance? You look for them on your gram stain. It's a system they call the Bartlett's, and what you have to do for us, and if you'll notice your gram stain sheet, look at that gram stain sheet, what it tells you to do for sputums. It's its own little column. On the gram stain sheet, if it's greater than 10 squamous under low power, the first thing you see, isn't there a section down there with enumeration on sputums? Does it say greater than 10, less than 10, greater than 25? You're going to have to see how your labs handle it. But a true lab, most labs are going to be very picky. If you have greater than 25 epithelials, when you count them under low power, they're going to reject it, ask for recollection because it was too much saliva, because of all the epies. The problem it becomes when you have greater than 25 epies and then you also have greater than 25 whites. What do you think every time you see whites? Infection. Some labs will still have you work it up if you have a ton of whites too. That's the gray area. So you'll have to see each microlab what they want you to do. You reject it if there's greater than 25 epies no matter what. Or if there's also a ton of whites, do you still set it up? The good sputum, so for our practical, on your last practical, is the clinical gram stain. You have to reject it if it's greater than 25 epies. And you say, nope, we got to recollect, we don't even read the gram stain. So what you've got to do, if you read, the goal is a good sputum is less than 10 epies, under low power, and greater than 25 white cells, under low power. That is a good sputum. Then you know you didn't have all saliva. So that is something they're going to expect you to be aware of when you go to clinicals. How do you assess if a sputum gram stain is a good one and you continue with the cultures? Remember, you don't want to waste money if it's not collected properly, because who pays for it? Patient. Any workup. Do you remember from your PowerPoint on 36 what stool needs 3 separate samples? Whole blood?
Parasites.
And parasites. Okay? And on 37, are cotton swabs good? What do they do? You should have remembered this from doing a strep throat. They can inhibit bacteria, so I was trying to see what this one says they are. Usually they're Dacron or Rayon. There's some synthetic, okay? Number 38, you should remember this from urines. What's your best, if you're telling someone they suspect they have a UTI and you have to tell them what to bring in, what are you going to tell them? Clean catch, first morning, midstream, and if you're from home, at least clean well after a shower. Otherwise, they give you the towelettes about wiping. And women, to clean all the labia is a big deal before collecting. What do you think on 39 are key things that you have to have? And what did you learn when you're the tech plating plates? Where do you label everything?
On
Back side, right? Media side. And it makes sense the lids could get displaced. And we wouldn't know who's what. So your date, usually they'll have some label with an ID number, and the name of the patient will be on the ID number and the date it was set up. And why did you need, and I shouldn't have circled all the media, she once only circled what is special media. So why did you need the CNA media circled on the back side? Because it can look like blood, and you want to make sure you're working from the right plate. You only want to see growth, no growth on the CNA, because what does it's selective for what? CNA grows only the gram positives. McConkey's grows only the gram negatives. So those, the CNA looks like a blood plate, so you don't want to pick up and work from the wrong plate. And also culture site. Every lab is going to have maybe R, like on our gram stains that we've been doing from labs, we put R for respiratory, we've put B for blood culture, we've put G for genital, we've put W for wound. So they might have RESP, they may have SPU for sputum. You'll just have to learn how they identify on their plate what culture it is. U for urine. That's what also would have to go on a plate when you're working on a culture. Number 40, what is the best way to handle a specimen for a culture? Common sense, what do you think is the best way? Process immediately. If you can in any way get it set up immediately. Even when we did micro at our lab called TriLab in Collinsville, if we got a spinal fluid, we'd set up the gram stain and we'd plate our stuff immediately, put it in the holding area till the guy could come and transport it to Collinsville. So process anything immediately if possible. 41, and then if you can't, then you got to know your way, your clinical transports them properly. So follow, one time, I don't know if I told you, I messed up when I was a student how an O&P was handled for parasites. It was a stool culture for ova and parasites, and I either processed it too late, not within the 45 minutes, or I did something wrong and they had to recollect the stool. So that wasn't good. You know, not like just getting a little urine from somebody. So I didn't follow whatever their proper handling for a parasite as a student. You know, mistakes are going to happen. The big thing is just own up to them and try not to make them again. 41, when you're looking macroscopically, this is something you don't have any experience with yet because we're not working with specimens yet. But if you're macroscopically looking at a specimen, think about our body fluids. What was the first thing on body fluids in your analysis that you worried if it might have cells and bacteria, if it was what? Clear or cloudy? So look and see if your specimen is cloudy at all. You're going to look and see if there's any blood or mucus. Those are things you want to note if you're the person processing. So your first week in micro, probably your first day, you're going to be what is called the setup bench. You're going to be the one plating them on the media that the techs will look at the next day. You'll be the one preparing the gram stain on whichever ones get gram stains. Not every culture, usually urines and throats don't get gram stains. Sputums, not even all places do genital gram stains. Memorial has gone to a molecular diagnostic way. They don't even do regular genital cultures. All of you probably were exposed to someone doing gonorrhea and chlamydia. Some places, I think Memorial, didn't they do them in their chemistry area? Or did they do their gonorrhea and chlamydia testing in micro? Okay, so they've changed. There was a methodology that they used that the chemistry people handled. So they have gone Memorial. So any of my genital gram stains I have to ask St. E's or Gateway, because Memorial does not do regular genital cultures. They've all gone molecular for them. I don't know what each site that you'll go to will do. So on the setup bench, you may need to write descriptors of what your specimen looks like. If they want to know if that sputum looked green and purulent, did it look bloody and full of mucus. So macroscopic will vary on what your site. So we will build to that come to the end, okay? You're going to mainly get your experience with real specimens at the actual clinical. 42, what did you do in hematology to look at your fluids, the diff? I'm assuming all of you had one. Cytospin. So the same way, if they had to process a fluid and they want to make sure they don't miss if there's bacteria, they're going to do a cytospin and have you plate the cytospin. And you already told me yesterday what are on the acid fast. Does anybody remember from yesterday the primary stain on the acid fast? No, that's the counter stain. Carbofuchsin, and what color is that? So it's different from the gram stain. It would be pink, clear, purple, because methylene blue is the counter stain. So on the acid fast, it would be colorless. And purple on your ones. The only ones that would stay too, because what do they have in their cell wall more of? Anybody remember on acid fast organisms, they have more lipids like cord factor wax D. 60% of their cell wall is lipids, and it maintains the carbofuchsin. What is the difference in the decolorizer? Is it acetone alcohol? Acid alcohol. So it strips everybody but 2 organisms. Do you remember? TB is the big one, Mycobacterium. They're acid fast all the way. You remember from your PowerPoint which one's partially acid fast? That should be Nocardia. So those should be the 2 you should have. And what are, we won't do clinical gram stains. Today we're going to look at pure gram stains. But the only gram stain that's really easy, and that's the one we start with, are blood cultures. Because you just give on blood cultures, you just tell what organism is present. You don't even enumerate. So that's the easiest easiest clinical gram stain to do. But if you're doing anything else, sputum, genital, wounds, fluids, you always have to tell them how many squamous epithelials, how many white cells, and how many bacteria types, and enumerate them. So when you look at that gram stain sheet I gave you, it tells you how many go with occasional, how many go with few. So this is a big deal. And I think this is the toughest part. You gotta find it on 100. Okay, this is my white cell with the lobes. Then you gotta put that in the center and go back to 10 and try to count all of them on that little low power. Laura and I were talking the other day. I wish they would have come up with a number for the whites and the epis that you would see on 100 on oil, because you can tell them there. It's really tough to see some cells, and some of the specimens, the cells deteriorate. So for you as an inexperienced tech to say, well, I think those are all white cells, when you go to 10, they seem so far away. This is the hardest piece of clinical gram stains, I feel, is judging your cells only on 10. So first you got to go to oil and find them. Then you got to put them in your center and go back to 10. Then you got to look for everything else in the field. And the field seems really big when you go back to 10. That looks like that. I feel to this day that's still very hard when you don't do them day in, day out. Okay? So don't get discouraged. A lot of micro is so ambiguous. It just, you got to remember, we're getting you to be entry level. We're not getting you to be experts coming out of here. We just got to have so they can build your skills when you're doing it every day for 8 hours. Okay? So on a preliminary smear, blood cultures is the only one. Those are easy. All you say is gram-positive cocci. You don't even have to enumerate. You don't even have to do anything but say, that's what's present. 45. You already kind of, so you tell me, you're a new tech, and I want to know, I'm going to give you a set of 24-hour plates, and you have 10 different ones. What do you have to do? Tell me what you did yesterday. That's what you got to do. okay? So you tell me the first step. What plate did you look at first?
The
Blood
blood auger.
auger, and what did you look for that? Hemolysis, and then what'd you do? Did you look at anything else on the colony?
Oh, the size.
Size
the
for sure,
color.
and color. If you can't get better yet, anything, at least try to put size and color and hemolysis. And it's always on the blood plate, okay? Then, Krista, what'd you look at next then on your 24-hour plates?
The McConkey plate,
And what did you need to say?
if it was a lactose fermenter or not.
But first you had to say G or NG,
Oh.
right? So if it's NG, what does that tell you you're working with? Gram positive. If it's NG, you've eliminated the gram negatives, right? Okay, then if it grows, you do LF or NLF. And the only other thing is a characteristic like mucoid for Kleb and Enterobacter, because that helps the tech. Remember, you may not be followed by yourself, so you got to make sure someone else can follow you. Okay, then Katie, tell me what was the last plate you had to look at yesterday?
The is it CNA?
And then what did you just want on that one?
You wondered if there was growth or no growth.
And if it grows,
It was-
and it tells you what?
Gram negative.
Positive.
Positive.
So we're lucky, this is the first time we've ever had enough CNAs to do it the first round. So you already know if it grows on McConkey's and the blood, it's a gram negative. If it grows on the CNA in the blood, it's a gram positive. That's already helped you, okay? So the first thing, by the end of this week, I am going to give you all the organisms of the 14, and I'll put them in little columns. What are gram positives? What are gram negatives? What is the yeast? Okay? Now, on 46, when do you report? When do you give the doctor a preliminary report?
24 hours.
24 hours. They want to know something. If they're on a blood culture and they see it's gram-positive cocci and they tell you they're in clusters, grape-like clusters, they're already thinking, uh-oh, they might have a staph. Especially if they say it was beta hemolytic. They know it's not staph epi. Staph epi is gamma. So if they see a beta hemolytic gram-positive cocci on a blood culture, you know they're probably going to start treatment for a Staph aureus. 47, do all cultures need a direct smear? And then give me one that does. A sputum is a classic one, and one that doesn't. Urine, they usually don't do them on urine. We already know 48, what are the two most common media you used yesterday? BAP and McConkey. And tell me why we streak for isolation. Why did you have to streak for isolation the organisms that you're going to work on today? What do you want by the third quadrant? Individual colonies. So remember, I think she said do a line like that, and you could do all three plates with one loop, right? You could do your BAP, your McConkey's, and CNA, take that same loop. This first quadrant, do you have to worry about your streaks crossing? Nope. On your first quadrant, you're just trying to get it to grow, so it doesn't matter if you go back and forth. But when you go, now you pitch that loop, you get your second loop. Do you remember why you started with the BAP? It is non-selective. Start with the least selective media. Because the others, you could drag some of that media that could inhibit bacteria if you use that first. Try to only go in here once or twice at the most. And then your streaks don't want to touch. And then you can use, that's a new loop, so you can then go to your third quadrant. And technically, you can keep that same loop and go over here, and then your third quadrant. So remember, you should be able to do all three plates with two loops. So today, you'll be able to see your technique, because you did your plates, you're going to be able to see, if you don't have individual colonies by your third quadrant, that tells you either you didn't change loops or you went too many times into the previous set of streaks. Try to only go once or twice. Okay? And today that'll tell you. You'll get to see your work. And your goal is to have individual colonies by the third quadrant. We'll get into amount later, but usually this is few, moderate, many, depending on what quadrant, or it'll be light growth, moderate growth, heavy. If it gets all the way to the third growth, that's either heavy growth or, depending on how your lab calls it, 3+, 4+. But remember, it's all about your technique. I won't, if you want to put 50, 51 in A, I'm not going to put that on the test. When we get to cultures, you're going to have to know that. But anybody, what culture on 50 do you have is for enumeration? And they are going to expect you to know this when you get to, and it's on your blood auger. On your blood auger, you'll take a loop from a clean catch with a sterile loop, and a lot of times you might make a drop right here and put a streak down it, okay? Then you'll do streaks all the way down, not touching. Some places will have you turn the plate and do streaks again. Most places will just do one set. And it varies if you use a 1 microliter, or I guess that's MCL, or a 10 microliter loop. I have 1 microliter loops. That is 0.001 ml. That is 0.01 ml. So Laura will teach you a technique, because urine cultures are the first thing we do when we do real cultures in week 6. You're going to have to take the number of colonies and count them. She teaches you to do them in groups of 10. So if I used a 1 ml microliter loop, which is what we have, if I had 100 colonies, I will multiply them by 1,000. If I use a 10 microliter loop, I will multiply them by 100. So this is 1 times 10 to the 5th. So this is something you don't have to know for test 1, but it won't hurt you to hear it now and hear it then. You all know you have a true UTI when you have times 10 to the 5th organisms. So if I told the doctor I had gram-negative bacilli, and I had 10 to the 5th, and it was a lactose fermenter, they're going to probably think I have a UTI with E. coli, okay? But if I only had maybe 1 colony, and I had 1 times 10 to the 3rd, unless that's the only thing growing, they're probably not going to worry about that being a true urinary tract infection. So this is ahead of the game. I'm not going to make you know it for your test 1, but it won't hurt you to hear, because by the end, you've got to know you plate a urine differently on the blood plate. And depending on the loop you use putting that urine, you have to count your colonies and multiply it. So I kind of like her way of doing groups of 10, like there's 10, there's 10. Because you'll think, oh my gosh. Now if the whole plate is full with individual colonies, you know it's greater than 10 to the 5th if it's the same organism. The problem becomes when there's more than one. Okay, number 50, you already know the hemolysis. So partial lysis is the green, clearing is the beta, no hemolysis the gamma. If on 53, at least look at size and color, every colony. Like she said, holding it up and looking on from the side view is a pretty easy one to see if it's raised or not. And then maybe take a look and see if it's smooth and round, or is it? Sometimes it'll have little projections. Someone look at the yeast today. think it's organism 7. Who had Candida yesterday? I know it was only one plate. Did you guys get it, Chris? You and Leah? Today, take a look, all of you, if the edges are smooth. They're sometimes not on yeast. I'm not going to test you on 54, so put NA, but what you're going to learn, do you remember from serology 2 things that have fevers of unknown origin? One is a meat packer disease, one is a Hunter's disease. Anybody remember? Francisella was the Hunter's beware, and Brucella was the meat packer. Anyway, those are 2 things that we're going to talk about in one of our PowerPoints, but they're rarely done in the lab, in micro. They're usually done in a serology test. So that's all that question is asking. The only thing I want you to know about 55 and 56, a lot of methodologies are becoming molecular type tests where they amplify DNA or RNA. Sometimes it's PCR, polymerase chain reaction. All I want you to know are the 3 steps of PCR, so circle that. Denaturation, primer annealing, and primer extension. And remember, you're going to get my key. So you'll study my key. So remember, the NA, let's keep track of the NA, and I'll put it on my key too, so that I know, I'll put it on mine that I know not to put them on the test.
And you said 55 no power?
Yeah, so no 23 through 29, put NA. I'm not going to expect you to know normal flora yet. No 50 and 51, put NA, because you're going to get that when we do urine cultures. And the only, no, put NA by 54. And 55 and 56, circle 56, but I at least want you to know that molecular testing, they're amplifying usually either DNA or RNA from your specimen to ID it. That's the basis of MoldyTalk. Now, I'm meeting Barnes on Friday. I'm going to ask them what molecular they do, if they can give me some examples to put on our clinical syllabus. And the lady from St. Anthony's, they have been nice enough to say they'll do 2. It's a great hospital in South County called St. Anthony's Medical Center off Tesson Ferry. It takes me, from here maybe 35 minutes, depending on how fast I get on 64. But she does a lot of molecular. And Deanna was our student last year that they hired in micro. She's going to come our last day when we do parasite presentations and do a little presentation on the molecular they do there. So when I go meet with them, I'm just going to leave a blank spot on our syllabus for molecular testing, and then they can write in what they do. She's going to give me a list of some of the stuff they do molecularly. So you're going to get exposed to that a lot now. Okay, so we'll try to start right at 10. So if you want, I don't know if they're doing hand washing next door. They have a new instructor, so she didn't tell me not to try to go in there. So just, look, if that door's shut, look, just knock first. But we're going to start with gram staining, but we'll wait till everybody does it together. And maybe when we get the plates, you can go ahead and make smears. I have a QC slide already. Just make a smear. Remember what plate you were, Amanda? Yesterday that you did a gram stain? You probably have the organism on you.
Yeah, it's written.
And then you can get that and make one.